Good afternoon. My name is David Moore. I'm a research scientist at the Center for Excellence in HIV in Vancouver and a professor in the Department of Medicine at the University of British Columbia. I'm here to present on our abstract on changes in the HIV care cascade among gay, bisexual, and other men who have sex with men in Vancouver, 2012 to 2014 to 2017 to 2019. I'm presenting this on behalf of my co-authors listed here. And I wanted to acknowledge that this work was conducted on the traditional unceded territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. We are grateful for the privilege to live, work, and play on these territories. And the authors of this abstract have no financial conflicts of interest to disclose. As many of you know, British Columbia has dedicated $48 million in additional annual funding to support expanded HIV testing and improved engagement and retention in HIV care since 2010. In this analysis, we compared HIV care cascade metrics for gay, bisexual, and other men who have sex with men in Vancouver across two time periods, 2012 to 2014 and 2017 to 2019. We examined data from sexually active GBM aged 16 years or older who gender identified as men and were recruited through respondent-driven sampling in two independent cross-sectional studies. Momentum 1, where enrollment took place between February 2012 to February 2014, and Momentum 2, where we enrolled participants between February 2017 and July 2019 as part of a three-city ENGAGE study. Participants completed a computer-based survey and tests for HIV and other sexually transmitted infections. For GBM living with HIV, we measured ART uptake through linkages with the BC HIV drug treatment program and directly measured HIV viral load at study enrollment. For the analyses presented here, we calculated RDS2 adjusted proportions and 95% confidence intervals for all variables for each time period. RDS2 weights are inversely proportional to the size of a participant's social network and were based on the question, how many men who have sex with men aged 16 years or older, including trans men, do you know who live or work in the Metro Vancouver area? We conducted separate analyses for GBM living with HIV to examine factors associated with having an unsuppressed viral load, defined as a viral load greater than or equal to 200 copies per milliliter, at each time period using logistic regression. Here are our results. We recruited 719 participants through 119 seeds in Momentum 1 and 753 participants through 117 seeds in Momentum 2. We found 199 participants confirmed as living with HIV in Momentum 1 and 132 in Momentum 2. The RDS adjusted prevalence for HIV was 25.8% in Momentum 1 and 20.4% in Momentum 2. But as you can see, the 95% confidence intervals with these estimates overlap between the two time periods. We, when asking HIV negative or unknown serostatus participants when they last tested for HIV, we found that 66% in Momentum 1 and 65% in Momentum 2 reported having tested for HIV in the previous year. These are the demographic characteristics of GBM living with HIV. As you can see, the age structure of the two groups of participants was similar in each time period, as was the self-reported annual income. We did see a decline in the proportion of GBM living with HIV who self-identified as white, European, or Canadian. And while we did see some increase in the proportion of participants who self-identified as other ethnicities, you can see that the confidence intervals for this estimate were quite wide. And for all other categories of ethnicity, we didn't see statistically significant differences between the two groups of participants. Similarly, when we looked at sexual identity, a lower proportion of individuals in Momentum 2 self-identified as being gay, and a higher proportion self-identified as other sexual identities. However, the confidence intervals with both of these parameters clearly overlap. As well, when we looked at gender identity, again, a larger proportion of participants in Momentum 2 self-identified with as having other gender terms in Momentum 2. But again, the confidence intervals were quite wide, indicating no significant differences between the two groups. When we look at the cascade of care, we found that undiagnosed HIV infection was already very rare in Momentum 1 at 0.4% and somewhat lower in Momentum 2 at 0.1%. However, the confidence intervals overlap between the two studies. In terms of receiving ART amongst all GBM living with HIV, including those that were undiagnosed, we found approximately 84% were linkable to the drug treatment program in Momentum 1 and 85% in Momentum 2. In terms of virologic suppression, we saw a larger proportion of individuals with a suppressed viral load in Momentum 2, 97.4%, compared to 82.3% in Momentum 1. And here you can actually see that the confidence intervals do not overlap for this metric. Interestingly, we had 12 participants in Momentum 1 and 11 in Momentum 2 that had measured viral load less than 200 copies per milliliter, but did not have an active ART prescription in the drug treatment program. When we look graphically at the cascade of care metrics, we can see that there's nearly 100% of GBM living with HIV were diagnosed in both study periods. Approximately 85% in both study periods were receiving ART through, at least identified as through data linkages with the drug treatment program, but that a significantly higher proportion of GBM living with HIV in Momentum 2 had a suppressed viral load. This is our logistic regression analyses looking at univariable associations of having a viral load greater than 200 copies per milliliter. In Momentum 1, we had a larger sample size to work with. It's approximately 35 participants had an unsuppressed viral load. And for these individuals, we found that having an ethnicity other than white, European, or Canadian was associated with a higher odds of an unsuppressed viral load, as was having an education level greater than high school, cocaine or crystal meth use in the past 6 months, and having a family doctor or ever being diagnosed with depression was associated with a reduced odds of having an unsuppressed viral load. Somewhat related to having a much smaller sample size in Momentum 2, we only actually had 5 individuals who had an unsuppressed viral load in Momentum 2. We are unable to find any statistically significant associations amongst some of the factors that we found as being associated with unsuppressed viral load in Momentum 1. We did find some associations with, in terms of social support, and some questions that were not asked in Momentum 1 actually did find some, an association with unsuppressed viral load. In particular, or having someone who shows love and affection a little or most of the time was associated with the reduced odds of having an unsuppressed viral load in Momentum 2 participants. This is the multivariable model for Momentum 1 participants. As you can see, all of these factors that I showed on the previous slide were retained in our final multivariable model. But we didn't have enough events in Momentum 2 to run a multivariable model. So, in conclusion, it appears that additional investments in the HIV care response or the HIV response in BC appears to have improved the HIV care cascade parameters for GBM living with HIV in Vancouver. Namely, there's still a very low undiagnosed fraction and very high proportion of individuals with virologic suppression amongst GBM living with HIV. In our analyses, we believe that ART uptake is likely underestimated and likely reflects the receipt of ART from non-drug treatment program sources, most likely clinical trials in Vancouver. But based on the virologic suppression data, it appears that BC appears to have achieved the 95, 95, 95 targets for this key population, at least in metropolitan Vancouver. Also, it appears that some of the disparities in virologic suppression that we noted in 2012, 2014 appear to have lessened over time, but perhaps social support for GBM living with HIV may be a key outstanding determinant for virologic suppression. I wanted to thank all of the participants, our community engagement committees, all our co-investigators, data analysts, programmers, statisticians, study staff, and funding agencies, all of whom made this work possible. Thank you very much.